Well, I think we're going to go ahead and get started. Certainly for many of us, the highlight of the conference is the keynote address by the MacLean Prize winner. And so I will be introducing the MacLean Prize winner at this time. I do just want to mention that for those of you who are local and are able to participate, we do have our interdisciplinary lecture series, which this year is focused on the topic of advocacy in healthcare and medicine. It's an outstanding series, Wednesdays at noon, and on the slides that will run between programs, you can download the entire schedule. And for those who are not able to attend, they are available on our YouTube channel afterwards. So with that being said, it is my distinct pleasure to introduce Mildred Z. Solomon, EDD, the 2024 MacLean Center Prize winner in Clinical Ethics and Health Outcomes. As many of you know, the MacLean Prize celebrates individuals who have made transformative contributions to the field of clinical medical ethics through scholarship, practice, leadership, and policy development. Dr. Solomon certainly exemplifies these characteristics. She is Professor of Global Health and Social Medicine at Harvard Medical School and President Emerita of the Hastings Center, the nation's first bioethics research institute, where she served as president for 11 years from 2012 to 2023. At Harvard, Dr. Solomon is core founding faculty of the Harvard Medical School Center for Bioethics, where she directs the school's fellowship in bioethics and has trained over 240 scientists, physicians, and other health professionals from across the US and around the world, many of whom play leadership roles in bioethics and healthcare. Dr. Solomon holds a BA from Smith College and a doctorate in educational research methods from Harvard University. Prior to working at the Hastings Center, she was Senior Director for Implementation Science at the Association of American Medical Colleges. Dr. Solomon's scholarship has addressed the ethics of end-of-life care for both adults and children, organ transplantation, research ethics, particularly related to oversight of comparative effectiveness and implementation science, as well as professionalism and responsible conduct of research. While serving at as the Hastings Center president, Dr. Solomon launched numerous new research initiatives, among them a major program on the wise use of emerging technology, which enabled scholars to define new research priorities and secure support from the National Institutes of Health, National Science Foundation, and other private foundations. In addition to encouraging and enabling the Hastings Center to do public engagement, Dr. Solomon encouraged research on public engagement. A 2021 report entitled Democracy in Crisis, Civic Learning and the Reconstruction of Common Purpose recommended ways to enhance civic engagement on controversial issues in health and science policy. Under Dr. Solomon's leadership, the Hastings Center broadened its focus to examine underlying social and economic factors like housing needs and social isolation that affect aging populations. This shift meant taking up the question of what a just society owes its oldest members. In 2020, Dr. Solomon made it a priority for the Hastings Center to advance health equity. It established an initiative that sparked a 2-day health equity summit in 2023 that brought together policymakers, medical professionals, and other experts to discuss solutions to address health and justice challenges. The summit was a collaboration with the Association of American Medical Colleges, the American Medical Association, the American Nurses Association, and the American Board of Internal Medicine Foundation. The Hastings Center also launched 2 programs to strengthen involvement in bioethics by students from groups historically underrepresented in the field. In addition, the Hastings Center report published a report on anti-Black racism and health that calls on the field of bioethics to lead efforts to remedy racial injustice and health inequities. As a crucial part of this commitment to diversity, the Hastings Center also expanded its work on disability. She is committed to ensuring increased diversity in the field of medical ethics. Dr. Solomon's commitment to medical ethics and her research, leadership, and mentorship make her the perfect choice for the MacLean Center Prize for Clinical Medical Ethics and Health Outcomes. Today, Dr. Solomon will speak to us on tackling the wicked problem of end-of-life care. Join me in congratulating her on this outstanding and well-deserved honor.
Wow, that was too much. So generous. Thank you so much. I can't say how honored I am by this award. It's extremely meaningful to me. So thank you, thank the selection committee for this incredible honor. Now, as you know, it's typical that people would state and show their conflicts of interest. I have no conflicts of interest to disclose, but I do have intellectual debts that I want to recognize. And one of them is to Dr. Mark Siegler for his many contributions. But I thought I would bring out, because I wanted you to see, Mark, that I have the second edition. I've had that on my shelf since it came out, but I wasn't able to find the first edition, so we're going to keep working on that. Dr. Siegler has affected the field in so many ways, including founding this center, but also in publishing what I think is one of the first, if not the first, guides to clinical ethics in maybe the world, certainly in the States, and did so with his beloved colleagues Al Johnson and Bill Winsley. So that's the one debt. My second debt is to the late Dan Callahan. Dan took me seriously as a very young researcher. I had the chutzpah to go and meet him at the Hastings Center. We didn't know each other at all. I remember the drive from Boston to New York. And I had an idea that I thought would help advance end-of-life care ethics in US hospitals, and he took me seriously. And as a result, we worked together for 7 years integrating new programs in ethics and ethics education in about 250 hospitals. Couldn't have happened unless he had really listened to a young person showing up at his doorstep. And third, I want to acknowledge a visionary leader in palliative care, Dr. Diane Meyer, who started the Center to Advance Palliative Care at the Icahn School of Medicine at Mount Sinai, and from whom I have learned a tremendous amount. Okay. So this morning, I want to talk with you about what is roughly a 50-year effort to improve care and well-being of the seriously ill all around the world, an effort that's gone on all around the world. And I'm going to talk about 2 independent but highly related efforts. One focused on trying to figure out the ethical principles that should guide our use of life-prolonging and life-sustaining technologies. So kind of the ethics framework for how we would make sense of life-sustaining technologies. That's one part of my remarks. And the second, then, is I'm going to talk about the history and importance of palliative care. And as most of you, probably in this room anyway, know, that's an interdisciplinary field focused on improving quality of life for those living with chronic progressive disease. And these are highly interrelated efforts, but they also have some distinguishing features. Now, I've had the privilege of working on both these topics throughout my career. I'm a social scientist and an empirical researcher, and in the late 1980s, I became interested in how American physicians and nurses would interpret emerging ethics guidance. Already, one important set of guidelines had been published by a special commission established by President Reagan. And I knew there was another set that was going to be coming out from the Hastings Center. And certainly the country needed that guidance. It was almost every day headlines in the newspaper about families suing hospitals to stop providing life-prolonging treatments they felt their loved ones wouldn't want. I know that sounds odd in 2024, because the nature of the cases right now is almost the reverse of that often, but it was in the paper every day, and it was causing enormous stress for everybody involved. And I became interested when I knew there were going to be policy guidelines coming out. As a social scientist, I had a lot of questions. For example, would the physicians and nurses they were aimed at even know about them? And if they did know about them, would they agree with them? Or would they feel that guidelines developed by philosophers and lawyers and some elite physicians, would it really reflect the lived experience of these doctors and nurses? And then, if it did, what would it take for the adoption of the guidelines in practice? These were questions that fascinated me. They're the questions I brought to Dan Callahan. And they're the questions that have really, they were my starting point. It is through them that I began my long search to use both empirical and normative methods to grapple with the challenge of modern dying. Now, as you'll see, I'm going to suggest that we have a lot to celebrate. Many people have been working together. Many of you in this room have been working together on many aspects of these problems. And we're going to do some celebrating. We're also going to do some acknowledging that there's still a very long way to go. And if you're a physician, a nurse, a physician's assistant, a social worker, or a healthcare administrator, I promise to describe at least a few things that you could do tomorrow. Okay, no one's getting off the hook here. There are things that are within your organization's power and also within your personal power to act on to help improve palliative care in the United States. And in fact, I'm going to consider my talk a failure if you're not inspired to become something of an agitator when you go back home. I'm going to start by sharing a true story. This one was conveyed to me by a very earnest young man. I'm calling him Brian. Brian was in the audience where I was giving a talk on end-of-life care, and afterwards, he nearly accosted me. He rushed up to the lectern and he grabbed my arm, and I remember his bright blue eyes because he stared right into me and he said, "So they didn't have to do that to her?" He was talking about his beloved grandmother. She had suffered a stroke. She had some cognitive deficits and some physical impairment, but she could signal pleasure and displeasure, and sometimes she could speak in short phrases. For quite a while, his grandmother recognized Brian and his parents, and she seemed to appreciate their visits to the nursing home. But then she suffered a second stroke, and she was left without the ability to speak or swallow, and a feeding tube was placed. Ultimately, Brian told me a tale of decreasing capacity and increasing dementia, fear, and unhappiness. She got pneumonia several times, and each time she was sent to the hospital for intravenous antibiotics, where her dementia worsened, and she returned to the nursing home more confused and more unhappy than ever. As the weeks went by, his grandmother was conscious less and less, and when she was awake, she would look at Brian and shake her head. He came to feel that she had had enough and that her constant returns to the hospital were a form of torture. He and his parents were on the same page about this. They asked that she receive comfort measures only and be allowed to succumb to pneumonia the next time she got it. But of course, or not of course, but in this case, the nursing home administrators were appalled, and they refused the family's request. Then matters got even more dire in Brian's view. His grandmother's kidneys failed, and the nursing home referred her for dialysis, despite the fact that she was unconscious most of the time. Brian and his parents were outraged and considered their legal options. That's as far as I will take the story. It serves my purpose of illustrating that the kinds of problems and challenges that Brian and his grandmother faced are relatively new problems. There was a time, roughly before the middle of the 20th century, when medicine could do very little. In the United States and other developed countries, people died primarily from infectious diseases and unexpected injuries. In the early 1900s, hospitals really couldn't do very much. They were basically settings for respite and support, where the very sick went to receive whatever comfort was possible. Death came when it wanted to. But by the middle of the 20th century, discoveries like ventilators, dialysis machines, and antibiotics changed that reality. Quite suddenly, over the span of a few decades, the timing and circumstances of death lay largely in our hands, in human hands. Today, it's been estimated that 70% of the deaths that occur in ICUs are made as a conscious decision by people, because they have to be, because our tools are so powerful at prolonging the life. And at the same time, thanks to mostly to public health and also to key advances in medicine, all of us are living longer than ever before in human history. But neither, and of course that's a good thing, but we aren't ready for it. Neither our families nor our societies are ready for this huge demographic shift. While we are living longer than our ancestors, like Brian's grandmother, we do so often with a fairly long period of time, very often suffering from chronic progressive illnesses and growing frailty. Now, I forgot to advance any of my slides. Fortunately, there's only a couple, like the title, which you already know. Okay. So in the developed world, and certainly here in the US, again, a lot of people already know, but I wanted to summarize what some of the very serious challenges are in trying to care for the seriously ill in aging societies where there's a high proportion of people living a very long time. And I won't belabor these because I do think this audience is familiar with it, but there are problems in both the overuse of non-beneficial treatments, like that dialysis when she was unconscious and near death, as well as the underuse of beneficial treatments, proper pain management, et cetera, or any other kind of high-tech intervention that might be palliative in nature are often underused. The next bullet goes without saying. Also, disparities. Not only do we have to work to be providing relief for pain, anxiety, depression, social isolation, but we also have to be attentive to the fact that while it's a problem across the board, there are also terribly unconscionable disparities in the extent to which people of color get pain relief. And we are, again, everyone in the room knows that we're spending more than any other country with no better outcomes. But in addition to the percent of our GDP that we're spending on health, there's a more personal toll for these costs in that medical expenses through being underinsured or through being fully insured but still having to come up with other, co-pays and things like that. Medical costs are the #1 reason for personal bankruptcy in the United States. And much of that occurs for the chronically ill and those seriously ill and near the end of life. So I think you'll agree that it was fair to call this constellation of challenges a wicked problem, which is what I put in my title. So what is a wicked problem? Well, they are hard to define, but climate change is a wicked problem. Trying to raise people out of poverty is a wicked problem, and so is end-of-life care. Wicked problems have no one cause, but multiple interacting causes. They can't be solved by technology alone because they engage conflicting values, beliefs, and preferences. They require debate and deliberation, and they evolve and are constantly changing over time. So they're dynamic, and they dynamically affect intervention in one domain will affect consequences in others. So that's what I would call, that's why I called this a wicked problem. And to confront it, we worked on many fronts. And I think it's fair to say that the first front we worked on was a conceptual one about the ethical principles that should guide our decision-making. And I'm going to call that front #1, establishing the ethical norms to guide bedside decision-making. We were captured by this question: when should it be permissible to use, withdraw, or forgo the use of life-sustaining treatments? Many of you in this audience who are alumni of the MacLean Center Fellowship or other clinical ethics programs are highly trained to learn how to help patients like Brian's grandmother and their families make these kinds of fraught bedside decisions. That's what our training is all about. But in the 1970s and 80s, there was very little guidance for these important health decisions. And just for the younger ones in the room who may not have seen this before, it was 1976 when Karen Ann Quinlan appeared on the cover of Newsweek, a young woman in her 20s in an irreversible coma. This was the first time that the issues were brought right into the public square through journalism. Karen Ann's father asked the court for permission to have her ventilator withdrawn, saying she would never want to live like this. It's not that her doctors were against it, but they were uncertain as to the legality of withdrawing her ventilator. They didn't know whether they might be accused of murder or of killing. And so they insisted that the family go to the court to have the court decide. It was decided in the New Jersey Supreme Court, which held that we should decide as we think Karen Ann herself would have wanted. In fact, the court's decision asked readers to imagine that Karen Ann could somehow wake up and look down from the ceiling at herself. What would she want? That is what we should do. And in the next 10 to 15 years, there were literally almost 200 similar court cases, all with basically that same shape, families asking physicians to stop. Now, basically the message was that patients have the right to refuse unwanted treatments, and if patients become incapacitated, those who know the patient best should attest to what they think the patient would have wanted. Now, later cases and ethics guidance established that this right applied to all kinds of medical interventions, not just high-tech ones, but also to antibiotics and to the decision to do chemo, et cetera. And other principles were articulated besides patient self-determination. Also, of course, the principles like do no harm and attention to issues of justice. And it wasn't just a legal consensus in these 200 court cases. In fact, the courts were hugely influenced by those 2 reports I told you about at the start of my remarks, hugely influenced by the National Commission and by the Hastings Center guidelines. These reports were independent of one another, but in high agreement, and that gave them a lot of credibility and influence. Now, today, the shape of many of these difficult cases is not at all like the Quinlan case. Today, the cases are often the reverse, with families demanding treatments healthcare teams believe will be ineffective and even harmful. And we're still sorting out, if you look at the literature in any issue that comes out in any of our related journals, we're still sorting out what to do with that. But the principle of self-determination was basically a negative liberty. It was the court saying that nobody can impose something that's unwanted. People get a chance to say, stop, you don't get to do this to me. But it wasn't a positive liberty. So demands for treatment, there isn't a right to demand treatment. It's certainly not a right to demand treatments that are ineffective or that violate physician integrity in some central way. We also have many critical questions we're looking at today regarding the proper use of rescue technologies like left ventricular assist devices or ECMO. Also, lots of technologies that were originally meant to bridge, to be temporary bridges to a more permanent solution, often intended for younger patients or those that are not as close to death, but now are becoming almost routine, even in the very old patients nearing death. There are a lot of, I've listed a bunch of other debates, but I think people in this room know what they are. My only point is that there is always a constant stream of new bedside ethics decisions and the need for emerging ethics guidance. But at the start, I promised there would be things to celebrate, and I think the establishment rather quickly of the ethical framework for making these decisions is really something to celebrate. It took maybe not that long from the time of Quinlan till the publication of these important documents that I've been describing. We actually established a commitment to a core of principles to guide these difficult decisions. Okay, and we also built an infrastructure. And by that, I mean things like the passage of laws like the Patient Self-Determination Act that requires hospitals to ask about advanced care directives, the development of curricula and fellowship programs, especially in relevant societies having annual conferences on this framework, at the establishment of ethics committees in almost every hospital and with case consultation services. So we built an ethics framework and we built an infrastructure for making sure it makes a difference in practice. So let's say good job on that front, okay? Good job. But wait a moment. There's a cup half full and a cup half empty. Despite our emphasis on autonomy and advanced care planning, the goal of ensuring authentic shared decision-making that respects the preferences and views of patients has not been achieved, not by a long shot. There's a lot of evidence of this, but I want to talk about one very insightful anthropologist, the late Sharon Kaufman. She wrote 2 books that I strongly recommend. One on end-of-life care, this one, in 2006, and another one in 2015 called Ordinary Medicine, Extraordinary Treatments, Longer Lives, and Where to Draw the Line. And she has described in a lot of detail, after hours and hours of participatory research, how patients and families, and sometimes doctors, actually do not decide about treatments so much as they yield to procedures. Many interventions that patients yield to and sometimes demand are not evidence-based, do not meet patients' needs, and introduce harms. For example, dialysis is frequently offered to patients in ways that they don't understand. It's fair to say that while patients may yield or accede to the recommendation for dialysis, they're not really giving informed consent, and they're not really stating a preference because the implications of it haven't been fully explained. Here, for example, Rebecca Schmidt and colleagues describe the prevalence of misunderstanding among patients agreeing to dialysis. Now, many patients don't realize they have a choice. 61%, there was an empirical study of these patients. 61% reported regret at having started dialysis. 85% said it was extremely or at least somewhat important to be informed about the option to withdraw. So here in this piece, there was empirical research, and then they wrote a conceptual piece offering suggestions for recognizing when the burdens of dialysis may outweigh its benefits and how to broach the conversation. In the case of dialysis, you could say that it's not so much that patients are making a decision so much as, okay, forgive the expression, going with the flow. They're following a default pattern. Sorry, that was bad. They're following a default pattern that inexorably brings them to dialysis. And this is very odd because for some time now, nephrology leadership has recognized the overuse of dialysis. Indeed, they have guidelines for the non-dialytic medical management of end-stage renal disease, and they've had them since 2010. Yet, and there is some motion. I know there's a book that's being planned right now, and a bunch of other actions that they've been taken, but still, there's much, much more to do. And dialysis is just one example I'm picking on this morning, but the point is that there are deeply habituated patterns of care that for large numbers of people offer very little benefit, or just let's say questionable benefit, about which there should have been much more discussion, and there wasn't. And there are these many examples. You could almost call them conveyor belts that people get on once they have a diagnosis. Of course, so what's driving these conveyor belts? One of the things driving this dysfunctional pattern is our fee-for-service model, which incentivizes overutilization. Another is the uber specialization of healthcare. We're organized so that patients are treated by specialists who are experts in specific organ systems and their related life-sustaining treatments. When doctors offer such treatments, patients and families naturally believe the intervention can restore health, even though the clinician may only be focusing on a particular short-term goal. In my view, a third barrier, those are two, but that there's also a third barrier in that clinicians have, forgive me, overlearned autonomy. And I think as bioethicists, another way you could put it is that we've overtaught autonomy. Rather than treating autonomy as an important principle that should be in dialogue with other principles, too often it's seen as the most important principle, even maybe the only principle. And when that happens, clinicians can end up diminishing their own professional integrity and their professional authority. Research I've done shows that they can sometimes turn themselves into technicians, focused only on asking patients what they want, rather than serving as professional guides, offering their experience and wisdom and helping to interpret along the way. There are many exceptions to that, and most of them are in bioethics, and they're in rooms like this. But if we look across at the kinds of typical care, the kind that anthropologist Kaufman documented, we can see this. And certainly in my own research, it became apparent. Early in my career, I documented this tendency to turn oneself into a technician in a variety of different settings. But the first one I did was in the context of trying to understand so-called feudal care. And this is a piece that I published in the Journal of Law, Medicine, and Ethics, the Journal of the American Society of Law, Medicine, and Ethics, how physicians talk about futility, making words mean too many things. And it was clear to me that these physicians were extremely well-intended. They wanted to help their patients make these kinds of difficult decisions, but they had some conceptual confusions, and they didn't have the kind of training in communications that was necessary to be able to hold these really difficult situations. And then much more recently, I think it was 2 years ago, I published this piece on patient well-being and professional authority. And I called it professional authority because when you turn yourself into a person who just says, what do you want? you are not only making it difficult to give patients and families the context they need to weigh in on what they want, but there's also a certain way in which that undermines authority that professionals should have. They should be able to share their wisdom, and if they're just asking and they think that autonomy is the predominant thing, then there's also an erosion of physician authority. And so I was arguing for owning that professionals have wisdom to share. And then this is a piece that Craig Blinderman, Eric Krakauer, and I wrote, and we were thrilled that JAMA published it, in which we called for a new approach to how we talk about do not resuscitate orders. I'm thinking about all the details in this approach, so I want to summarize it for you. Basically, we were saying how poorly the DNR order is currently broached with most patients, and how easy it is for patients and families to feel that if the physician is bringing up cardiopulmonary resuscitation, he or she must expect that it can bring some benefit. Why else would my doctor mention it? Our paper offers a new way that would avoid that misunderstanding by we lay out the whole approach, but the bottom line is, in cases where CPR is unlikely to offer meaningful benefit, we discourage offering it. Instead, for reasons explained in the paper, we encourage physicians not to offer CPR, but to frankly disclose that they aren't, and to explain why in a more detailed conversation that can provide more context. Now, many other people have been talking about the importance of giving training in how to hold these very important conversations. One of the best papers on this is a recent paper by the MacLean Center's own Peter Angelos, in which the kinds of recommendations that are being made here that are directed to surgeons for how they can hold these conversations. This is a very wise paper with many very helpful suggestions, and so although he won't brag about it, I can brag about it and hope that people will be sure to take a look at this. Among other things, this group of authors is recommending that that scenarios from the best case of what might happen to the worst case should be laid out in this conversation. And they even have a heuristic in the paper to show what they mean by that kind of scenario planning. And I just think it's a really wise paper. And it's addressing the same problem I'm trying to describe, of the importance of providing context, not just, I guess, there was an expression you had in the paper about being abandoned to their autonomy, not just abandoning patients to their autonomy, but actually being an expert who can help guide them and not concealing one's expertise. Okay, and then I just want to mention one other thing I think we need that would be a helpful remedy. It would be to have a quarterback on every unit or service in a hospital. Someone responsible and accountable on every unit for convening a family meeting with the key clinicians. And I really mean key clinicians. This people should be from all the different specialties that are caring for this patient. Otherwise, each specialist remains in his or her own silo, willing and able to offer top-shelf interventions for the body part or the body system they're responsible for, but nobody is helping the family and patient make sense of all this. I think a lack of these meetings and the absence of a quarterback who can call and manage the meetings are system failures, grave system failures, with real consequences on patient well-being, family financial burdens, and national healthcare costs as well. So, even if we have, and I'm just gonna make this even worse, even if we have a quarterback ensuring excellent shared decision-making, that alone also is not enough. And the reason is it still is focusing primarily on bedside decisions. So that puts the focus on whether to use or forgo a particular intervention. But it doesn't help us start to think about how can we build systems of care that deliver comprehensive palliative care. So that's the second front that I want to talk about. Designing systems of care to support those who are living with chronic illness. Again, this is really a wicked problem because it's about sorting out, not only sorting out these treatment decisions, but how we support living with chronic illness. So I want you to meet Joseph Andre and his daughter Maureen. This is a true story that was chronicled by the journalist Nina Bernstein in the New York Times in 2014. At that time, Mr. Andre was 91 years old. He had multiple chronic conditions and functional dependency. He had no cognitive decline, though. He knew his situation and he knew what he wanted, which was to be cared for at home among his beloved books and CDs. His daughter had to work, but she did a great job of taking care of him as she could. She came home every evening after teaching school all day to ensure he had supper and help him get ready for bed. And this worked for quite a while, and it worked primarily because he lived in New York, where there's very generous Medicaid support for his help. But none of that was enough. And over the last 2 years of his life, he had unnecessary revolving door stays at nursing homes, emergency room visits, and hospital admissions. All he really needed was logistical support in his home. But instead, he was admitted to nursing homes that were terribly understaffed. He developed pressure sores and ultimately a systemic infection. He was miserable most of the time with no cognitive impairment. He knew that he was abandoned and neglected. Over the last 2 years of his life, his care cost $1 million for many health problems that arose primarily from the care settings into which he was being transferred repeatedly. He knew he was dying. He was not demanding medical treatment of any kind. He had a healthcare agent in the form of his very informed daughter, and they had clear goals for his care, which were to keep him comfortable at home. In other words, they had done their part with good advanced care planning. They had done their part. But this is a problem that should not and cannot be solved by a family alone. The system didn't do its part. So in response to these kind of realities, one of the responses has been enormous growth in the field of palliative care. And for this group, I'm not going to read all these because I think you all know what palliative care is. And this is a second place to celebrate because a lot has been done to establish this field, to provide kinds of care that Mr. Andre needed. In the mid-1990s, American philanthropy invested $200 million to help establish this field. That's not very long ago, right? It's about 30 years ago. And today, let's see, telling you this history, as I say, you probably know it, so I'll be very brief, but I think it's quite a heroic story that in 2006, not many years into the effort, we had palliative medicine certified as a subspecialty by the American Board of Medical Specialties. The funds also of this American investment created new fellowships. Now there are 100, last time I looked, which was about a year ago, there were 188 fellowship programs around the United States. And that has resulted in approximately 7,600, almost 8,000 board-certified palliative medicine specialists. That's pretty amazing. It's not enough. No way is it enough, but it's really something we should celebrate. And most major hospitals, including almost, I think, all academic medical centers, have palliative care programs. There are journals and textbooks, and the National Quality Forum has even created validated measures to use to evaluate those programs. And there's a growing body of research, not enough, but a growing body of research, including randomized clinical trials that demonstrate the effectiveness of palliative care in all these domains that are shown on the slide. However, this cup is also both half empty and half full. First of all of our financial incentives are backwards. The greatest share of our national spending is going to hospitals, imaging facilities, and other technologies, drugs, specialty visits, etc. Medicare will pay for all manner of high-tech interventions, but with the exception of hospice, it will not pay for the low-tech, high-touch interventions so greatly needed by millions of people like Mr. Andrew. That's why, dare I bring this up? That's why many of us were gratified to see Kamala Harris recommend that we expand Medicare so that it can cover some of the costs of social supports and care coordination for people diagnosed with serious advanced illness. So, in short, one of the things we need is financial reform to support home-based services and care coordination. And in fact, in 2017, Congress passed a bipartisan act that allows Medicare Advantage plans to design benefit structures that vary benefits and would allow for some more payment for some more of these things. So, although it might not be the right moment to say this, this could be a topic that wins bipartisan support, since we've already got an example of an act that was done, and since all of us have grandparents and parents, I'd like to be optimistic about that. The second thing is that palliative care has never been required by, hospitals have never been required to have palliative care programs for hospital accreditation. So I think this is another area where, in terms of national policy, it should be required for hospital accreditation. Right now, there's 2 hospital accrediting bodies for for US hospitals, and neither one of them has required this in order to accredit the hospital. This one change alone could help secure the viability of existing programs and encourage the establishment of new ones all over the country. Third, licensing bodies should require demonstrations of competency. There are lots of curricula that were developed with that $200 million. There's wonderful programs. But they vary in quality, that's one issue. And the second issue is that although people are required to take them, the ACGME requires that, they're only required to take them, not to demonstrate that they've actually developed the competency. And so, there's no, that you can read about how to hold these conversations, but unless you're asked to actually hold them in mock scenarios and evaluated for how you did it, it's unlikely that you've developed the skill. We wouldn't allow surgeons to operate before having demonstrated their surgical competency, and yet we allow this to happen without any real way to evaluate the competence, the actual competency. So these are 3 levers for change. And once pulled, they can supercharge the development of palliative care. Diane Meyer and her colleagues at Mount Sinai presented these ideas in a very important paper in Health Affairs, calling for a national strategy, and they say a lot more about those topics that I've just introduced to you today. Now, in the last part of my remarks, they're brief, but they're really where the rubber hits the road. I know that many of us, and many of you who are active clinicians, are not going to be able to make much change in these big national levers that I'm talking about. You're busy clinicians meeting with patients and families, and you may not, it's not appropriate to think that you're going to help us change our financing reform or make a difference in hospital accreditation and licensing of physicians in training. But there are things that you can do tomorrow yourself or that you can influence at your institution. And I want to end on that note of the many, many things that I do think are in your power. And you can contest that with me in the few minutes we'll have left for discussion, but let me assert it anyway. Okay. First of all, you can, if you have a palliative care program in your hospital, it goes without saying that you can refer patients to palliative care early at the point of diagnosis, not just for those who are near death, which is a misunderstanding. There's plenty of research that now shows that early integration of palliative care at the time that chronic illness begins is very, very effective. So that's one thing you can do. Just use the expertise already in your institution, or encourage the other colleagues, because this room, again, probably already does that, but encourage your colleagues to do that. The most important thing, I think, is to disrupt those default patterns that Sharon Kaufman documented. Disrupt the default patterns to ensure that goals of care conversations occur within your own unit or service. And if you're going to do that successfully, you're going to need someone or a small team to serve as that quarterback. And I've seen this happen at the unit level or the service level in hospitals, not writ large, but like on this ICU, when certain trigger events occur, when there's certain indicators or markers are met, they know that that's going to stimulate a goals of care conversation. And if this is going to work, we have to screen for patients who will benefit from palliative care. And there are some very well documented ways to screen for them. You can't hold a meeting if you don't know who you're holding the meeting with. How do we sort out who the audience or participants in this are going to be? One is that many of you may have heard of this surprise question, which is highly validated, originally invented, so to speak, or envisioned by Joanne Lynn, but now documented in a number of studies. You simply say, the question is, who would you not be surprised if they died in the next year? And amazingly, that has good predictive value for who you should be holding these meetings with. And it has even better predictive value if the nurse and the doctor are asked that question, and if they have the same answer, then it elevates the predictability of that. And then, of course, in different specialty areas, there are different biomarkers that are relevant to the diseases that specialty treats. And you can do a combination of the surprise question with one or two biomarkers, to figure out who are the patients we want to develop these conversations with. Also, each of you could work with your own specialty or subspecialty fellowship directors and encourage the fellowship directors to require learners, this would be for academic medical centers, encourage them to require learners to demonstrate is the word I should have put in orange, their communicative competency and their knowledge. Fellowship directors know that they're supposed to offer training. They don't know that they have to require documentation. Enhance your own skills through participation in high-quality training yourself. And again, I say there's really very good programs. The Center to Advance Palliative Care has something called Vital Talk, for example. And I mentioned earlier that the National Quality Forum has validated measures. You could go find those measures, they're published, and use them to assess how your service, your unit, or your hospital are doing on these measures. And then the last thing I want to mention is, for those of you that want to do research, you can make palliative care a research focus of your own. Research is very important for a number of reasons. It's important because it's the way to ensure that palliative care remains evidence-based, but research findings also lead to progress in other areas. Once a study comes out and shows impact, there are positive consequences. Let me see if I can figure out how to show that. I have a very fancy slide next, but it does too much and I don't have a keypad. What this is supposed to do is scroll. And not because I thought you could read these, obviously you can't read them, but imagine it scrolling. And what I was trying to demonstrate is that, For example, Jennifer Temmel was the first author of one of the first and most important studies. It was conducted at MGH in Boston that demonstrated the early integration of palliative care in cancer treatment, a particular kind of cancer treatment. I think it was lung cancer, and a particular kind of lung cancer. Anyway, she proved that it was effective in symptom relief and in a whole variety of ways. And what was really a shocker about her study was it showed longer longevity. Many people don't want to refer to palliative care because they think it's like a doom referral. And in fact, her study showed that patients who received palliative care support lived on average about 3 months longer. And the reason this would be scrolling is to see what happened next. What happened next is there were editorials. ASCO got together and created guidelines, the American Society of Clinical Oncology, and a whole variety of sequelae. Then another specialty area, heart failure, realized that they could do in their area what Jennifer Temmel had done for lung cancer. And there's like a very nice building effect that the research creates. So that's what my scrolling slide there that was going to show you all the many things that happen. You can imagine, it's for you to imagine now. All right. So it's obvious from my list of things you can do tomorrow that there are, in fact, an awful lot of things that you can do. So. I want to say one more thing about Temmel, because this is one more thing you could do. Excuse the out of order comment. So she isn't a palliative care doctor. She is an oncologist. So she teamed with palliative care doctors to do that study. So that is an important message. We're going to need people. There's not going to be enough palliative care specialists anyway. There's no way we can train that many people. But doctors from various different specialties can reach out and can begin to figure out how to do early integration of palliative care in their respective areas. So there are many, many ways to get involved. Let's think of Brian, of Mr. Andre, of Brian's grandmother, of our own grandparents and parents, and ourselves. And let's do something. The end.
I think we have time for a few questions if anyone has any questions they'd like to ask.
A hidden player here, which you mentioned once, is the profit motive. And you're working on one side of the equation of how do we treat these things. There's the other side of the equation, which is people trying to do, from your perspective, damage. And how do you confront the profit motive to make it less of a factor?
Vote for health policy. Vote for people who you think stand up for the health policies that you want. That's the first thing that comes to mind. Yes, I said that fee-for-service was.
Do you mind just using the microphone?
I was trying to see who was speaking.
Thank you.
Yeah, sorry. Yeah. No, I completely agree. And I only gave it one, you're right, I only gave it one line. I said that fee-for-service was a huge driver of overutilization. And that's true. And that is, I'm sorry, I think that's a political problem. We just don't have the willingness, although there are forays. So that there was a bipartisan act in Congress in 2017 that has allowed Medicare Advantage to experiment with different kinds of benefit packages and value-based payments that will allow people to, not be driven by utilization. The interesting thing in our system, and again, a wicked problem, is that, and the reason that we need research, is that both a fee-for-service model incentivizes overutilization, as you said, and the value-based payment where the health entity takes on the risk and is paid a fixed amount, that is going to incentivize underutilization. And so another reason that research is really important is to catch those dysfunctional consequences of both those models. I would like to turn the question back and say, that's a huge question and a really important one. What do we do in a system in which it's become, there are so many financial motives for the healthcare organizations and also for individual physicians. In New York, we're seeing more and more doctors refuse to take Medicare patients. I can't understand how that can be permissible. I mean, it's the one federally funded healthcare benefit we have for people over 65, paid for out of federal taxes, and I don't understand how there can be an ethos in which physicians feel that they will not take those patients. I don't understand that. So the financing of this is critical. And you're right, I stayed mostly on the other side because I don't really know what to do about it.
Hello, I apologize for my voice, cold, 'tis the season, but I really appreciate your excellent work in this area. I'm a primary care doctor who also does hospitalist work, including ICU, and we see this problem come up all the time. The lack of a quarterback is a huge problem, and I think part of the issue at our institution and other ones I've worked at is that sometimes palliative care, while they're immensely beneficial, you're right, they only get called last minute. They only get called where people think that the team is maybe making the wrong decisions. It's often too late to change a lot of things, but it's also leading to a little bit of learned helplessness from the other staff, where they will say, oh, this is a tough problem, call palliative care. I don't know, just talk to palliative care. They'll be by later today. What did palliative care say we're gonna do? I guess we have to do that. And I think while I really don't want to downplay the wonderful work that is necessary and needs to be done, I worry that it's another facet of that hyper-specialization that can leak into systems that engenders that learned helplessness.
That is a great, great point. And basically, if I may, tell me if I'm restating this particular aspect right or wrong, but what I take away from what you're saying is we need generalists who are willing to, who have a certain modicum of training themselves, so that they can hold conversations that are really high quality, and not only because there aren't enough specialists, and there never will be enough palliative care specialists anyway. And there's also this moral problem that people might just shove it over there and feel it's not their responsibility. So thank you for that comment. Great comment.
Thank you again.
Thank you for this great talk. If it's okay, I just wanted to add, I think, 2 more things that maybe folks can do. And I think one is learning about, but also talking with your hospice providers. And I realize palliative and hospice are different in many ways, but actually calling the hospice clinician and speaking with them about what is possible. I think as a palliative care and hospice physician myself, I think that people make assumptions on what can be done in the home and what we can do in the home with hospice. And I think it varies by agency. The payment model hasn't changed since the 80s, so we have financial constraints as well. But we can do a lot. And so we don't have to wait for what I think folks think we have to wait for in order for someone to be ready for palliative, because we can continue to do several things. And the second one, I think, is making sure that we're embedding education for learners in what the post-acute care setting looks like. Come see us, come with me to the SNF. Let's go see an LTAC and actually understand what that means for patients. And we have data about what it means for their mortality. So I do think that in order to expand our minds on what palliative can be, I think we have to understand those 2 areas of medicine a lot better.
Thank you. Those are great ideas.
Yeah, I just had one comment about the financial considerations. As a prior consultant, I worked with health systems a lot that were formulating value-based care, and What's really, the leading health systems are doing a lot for these social inequalities, and now they're actually being financially reimbursed for it. So you see health systems providing housing, for example, food insecurity. We have, I actually helped create grocery stores in hospitals for this exact reason, to help patients get actual nutritious food. And so I think finally we're starting to turn that corner where we can say, yes, there's a financial benefit, and even folks on the other side of the aisle can say, yeah, there is a capitalistic goal that can be achieved with doing these interventions that are more social in nature. The second piece of this, I think you brought up a good point in terms of primary palliative care. And so understanding, I think the big question I have to you is, how do specialists develop those primary palliative care tools? Because we need our specialists to have those tools available to them so that they can start these conversations. Because as you mentioned, we just don't have enough palliative care doctors to fulfill the need.
Yeah, curiosity. That's my answer. If you're a non-palliative care specialist, become curious about palliative care and what the basic minimum knowledge and skills should be for everybody. Speak to the palliative care program in your institution, if there is one, and tell them you want to do that and you want to lead it for the attendings and the residents in your service. Also, there are all kinds of workshops, right? Hospice and Palliative Medicine offer things, and the Center to Advance Palliative Care also offers. So I think it starts with a desire. And that's really what all I was trying to do today, was to say, if you're not a palliative care doc, show some curiosity and put a little bit of time and effort into it. Also, you can ask your fellows to start to make that be part of their fellowship experience.
Last two questions, yes.
Yeah, thank you for the talk. I wanted to return to an idea that you mentioned, a kind of diagnosis of some of the problems you're talking about, the idea that clinicians have overlearned autonomy. And so there's another diagnosis of the problem that is more friendly to autonomy, and I was just wondering what you thought about it. So the other diagnosis is this. Part of the problem is that clinicians have learned, or some clinicians have learned, a sort of narrow view of autonomy on which respecting patient autonomy is just incompatible with attempts to persuade patients that certain treatments aren't beneficial and to guide them. But I mean, the solution then seems to be to sort of expand our conception of autonomy. Another part of the diagnosis is that we've placed too much emphasis on respecting patient autonomy and not enough on respecting clinician autonomy. So clinicians should be given, there should be some space carved out for them to have the right to not provide clearly non-beneficial treatments or treatments that fall out of the standard of care. But again, that's sort of, so addressing that problem would require expanding our conception of whose autonomy to respect. So I was just wondering if you had thoughts about that other diagnosis.
Yeah, I actually think they're related, and I agree with both sides, and I thought I was mentioning it, but probably didn't as strongly as I should have. The paper I wrote in the Hastings Center report called Patient Wellbeing and Physician Authority, I really went out there and I said physicians are undermining their own authority, and their authority is important because they have experience and knowledge that should be offered to patients. If you support patients making informed decisions, you have to support clinicians sharing their expertise. That's why it's shared decision making, right? So I don't think those are really different. I think they're different sides to the same difficult, hard to crack nut we've got.
Hi, my name's Jenny Kingsley. I'm a pediatric intensive care doctor at Children's Hospital Los Angeles and a clinical bioethics consultant for the hospital. And you mentioned a couple of times, and I think this dovetails into the previous question of, in my practice, I am now seeing more and more commonly a request for potentially non-beneficial therapy, and we have the flip side of this coin. And I think there's important parallels as we've drawn in terms of authority, ownership, sharing of expertise. But what are some of the I'm hoping you can make more explicit for me the lessons learned over your career that we can apply looking forward to this emerging issue.
Well, thank you. Are you in a pediatric ICU or a neonatal ICU?
Pediatric.
Yeah. And what you're seeing is more demands or from family to do things that you think are not in the child's best interest.
Correct, despite sharing expertise and knowledge.
Well, I'm going to try to be succinct in my answer, but this relationship between adult medicine and pediatric medicine is something that I grappled with a lot in my career. You put the question to me very broadly about my career, so I'll start there. When we first developed educational programs on that ethics framework, which is what Dan Callahan kind of green-lighted, and we worked in hospitals. We made after the Quinlan phase in the late 80s, like 10 years later, we made a conscious decision to work on adult medicine first, and only in the first 10 years of our work, we only focused on adult medicine because we thought it was easier. You could rely on the importance of patient self-determination. That doesn't exist in pediatrics. The autonomy card is not one that really can be played since infants and children do not have self-determining capacities. And then it raises the whole difficult conversation about what is the proper authority the parents should have. And you want to maximize parental authority, of course, because we have to assume, in most cases, not all, that parents' beliefs are well-intentioned and are often the parent knows best. So there should be deference to parental discretion, but it shouldn't be absolute. And we developed, after the adult stuff we did, then we had another 10-year period where we were doing pediatric palliative care. And we felt the need to create a kind of a different conceptual framework because we didn't have autonomy as the anchor. And we proposed that you imagine cases falling on a continuum. And at one end of the continuum, care is definitely beneficial for the child, and the parents don't want it. And in those cases, we said parents should be trumped because the patient is the child and it's the doctor's responsibility to take action to protect the child. It doesn't matter if if there's clear evidence that is, beneficial. Of course, there's disputes about whether something's beneficial or not, but you can also imagine cases where there's pretty strong consensus. And we sanctioned overruling parents. At the other end of the continuum, there would be consensus that the treatment was not beneficial and harmful, even harmful. That harmful one's even further out on that line. And we said, again, that at that extreme, parents could be, trumped, that parents can be overruled. Because nobody can insist that this is the physician integrity issue. It's not really only authority, but their integrity would be violated if they did something they didn't believe was in the child's best interest. At those ends of the continuum, we thought it was appropriate for physicians to act, even if the parents didn't support them. But we emphasized that there's a huge number. Most of the cases are somewhere in that middle area, and that we should be leaning towards giving parents the greatest discretion possible, the greatest authority possible, but it's limited by those other cases. So I don't know if that answers your question.
We're going to have one more question.
All right. I'm Joel Lucas. I'm a freshman with the high school group here. So I was wondering how a high school student can have an effect on this mission, or how we can take part in this.
Wow. Well, first of all, I'm so glad to see you here. That's amazing. That's wonderful. Okay, it just so happens that in my long career, see these wrinkles, the NIH provided funds for us to develop a curriculum for high school science students. And I think it's still on the web. There's 6 modules. And it's free, and if you can't find it, find out how you can reach me, and I'll get it for you. It's designed specifically for high school students, so you could download that and you could teach it to your peers, or you could bring it to your teachers and suggest they teach it. It was designed for use in 10th grade science, 10th grade biology classes, and it was field tested in 50 schools. But we know from that field testing that it doesn't have to be a 10th grade science class. So, I mean, I've used it with medical students, and it can be adapted in all kinds of ways. So it's there for you. And boy, maybe you can keep coming to meetings.
Yeah. Thank you.
We're going to take a break for lunch now. We're going to reconvene at 1:30. And at 1:30, we're not reconvening here, but at 1:30, it's for the small breakout groups. And so look at the program, decide which you want to go to. There are 3 starting at 1:30. And if you're not sure where the breakout group is, just check with the front desk and we can direct you. Thank you.